chock block of malignant cells, monomorphic in appearance. Next slide. And when you look at them in detail, you can see this kind of a sieve-like nucleus with prominent nucleoli inside them. Little bit more cytoplasm than before. These are all blasts. Next slide. Look at this, all blasts. Next slide. This is another patient's slide. I put it here so that you'll appreciate that these blasts are bigger, much more cytoplasm, but they are not as blue. They are light blue in color. And indentation of the nucleus. This is actually an AMMN, acute myelomonocytic. The monocytes tend to have an indentation in the nucleus, larger cells with much more cytoplasm. So this one actually an AMML. Go to the next, previous slide please. So just for the sake of comparison between these blasts with a much more darker cytoplasm, go to the previous one. Much more darker cytoplasm. Yep, and go to the third slide now. And if you compare it to that, much larger cells these are, hardly any, much more cytoplasm, very light. Look at this nuclear indentation inside them. These are myelomonocytic, and there are some more over here, picture in picture. Look at this indentation over here. Look at this. These are monocytic. This is an AMML. Next slide. This was the AML biopsy of that same patient, the previous one, and look at the ALL biopsy which I had shown you. I mean, it's sometimes very hard to differentiate between the two. You can do an IHC, but really, I mean, if I don't give a clinical history, it's sometimes hard. Of course, there are histopathologists who are brilliant and they will give me an answer, there's no doubt. There are people who just put the slide on the microscope and say ALL, AML, you know, they are brilliant, there's no doubt. But in this case, you will need immunohistochemistry to differentiate between the two. Next slide. So in this case, the peroxidase in Sudan was positive. 1333 came out to be positive along with DR. Please remember, myeloid leukemia, 1333 HLA-DR. This is the mantra that you need to have for immunophenotyping. And then cytogenetics was done, but it was negative for everything. Why do we need cytogenetics? Because 1517 in an AML, M3, has the best prognosis, brilliant to treat. Has maximum problems the first 1 month, but if you treat them and they go into remission, they are almost cured 80 to 90% of the time with the present protocols that are available. Next slide. If you are seeing that the entire population is now shifted upwards, so it is a shift to left. Next slide. And what was seen on the peripheral blood were these cells. Again, they were large cells. Again, indentation like that of a monocyte. But can you see the polar granularity here? That's polar granularity. There are myeloblasts over here, and there are polar granularity. Now, this is actually, the pathologists call this as monocytes, and one also has reported as atypical activated lymphocyte. Actually, these are pro-myelocytes on the peripheral blood. But because of the virtue of their appearance, it is very common sometimes people say, okay, they are monocytes or they are activated lymphocytes. This is actually polar granularity, which you will not see in monocytes, which you will not see in activated lymphocyte. This is a pro-myelocyte. You can see a prominent nucleus over here also. Next slide. If you see further over here, there is an indentation here, a little bit of granules here, polar granules, and there is a nuclear indentation here. Can you make out that wedge? Very typical of pro-myelocyte. You can see the nucleoli over here. Next slide. You can see again the wedge over here. These are pro-myelocytes, and you can see the beautiful wedge with polar granularity here. Very typical of pro-myelocyte. This is an APML. Next slide. We'll come to immunophenotyping, and I'm just going to spend some time over here before we take a break. It's an hour. So we'll just take a. There are 3-4 slides on immunophenotyping. Then we take a break, and then we'll come back to the remaining slides. Why am I spending time on immunophenotyping? Because we are going to a world when we need evidence. And we all, as pathologists and immunologists, know that sometimes on the peripheral smear or marrow, we may or may not come to an answer. And in today's world, we want to be more and more careful. We want to do more evidence-based medicine. So immunophenotyping done by flow cytometry allows rapid collection and objective analysis of multi-parameter data, which reflects the morphological and surface antigen structure of leukemic cells. Therefore, it can give us a much better insight into what we are dealing with. And in the next 3 or 4 slides, I'm going to show you why immunophenotyping is done only for those patients who want to undergo therapy. If people do not want to undergo therapy, there is no point in spending money on this. Cost of this will vary between 3,000 to about 8,000, depending upon which center you are getting it done. So, justification of that cost is important. If you are able to get an answer to peripheral blood and you don't want to do therapy, there is no point in doing this. But you're going to do therapy. So why can't we just go by morphological diagnosis and we are confident and go on with therapy? Why do we need this? We need this, and I'll show you why. But we also need this because we need to characterize leukemia. And if a patient is going to spend 8 lakhs to 10 lakhs on leukemia, they can spend 10,000 to get an answer, certainly. So I would insist that for those who are undergoing treatment, this is also important from a medical legal point of view to see that you have done everything right and the intention was to get the answer. So I think it is worth doing this. Next slide. As far as immunophenotyping is concerned, to pick up myeloblasts or myeloid markers as we call it, it is necessary to have 13, 33 and HLA-DR. I don't know why I missed out. The HLA-DR should be over here. 13, 33 HLA-DR. We can also use 11B, but routinely it's not being used. The 13, 33 HLA-DR is the most important. That will pick up myeloid markers, most common. If you are suspecting a monocytic variant to that, then you have to do 14 and 15. You can also use a CD64, which is not easily available, but 14 and 15 is available. So the person who is doing the immunophenotyping has to be told by the referring hematologist what he is suspecting or she is suspecting on the bone marrow. Also, the person who is doing the immunophenotyping should see the slide, because in order to gate the cells for immunophenotyping, you should know what the morphology of the cell is, what is the size of the cell, so that they know which population of cells to gate. So whoever does immunophenotyping has to see the slide, and then they decide how to gate the population and find out what is it. Okay? And also by looking at the slide, we can know whether we need to add 14 and 15 as additional markers. Otherwise, this will cost more, and therefore many people may not want to do it. Also, some people, as you know, have panels, leukemia panels. They may not include this, and then they say, look, now if you want to know whether it's AMML, it's AML all right, but if you want to know it's AMML, please pay additional 1,000 rupees for this or this to be done, which means a time delay. You have to contact the patient and get back. So it's nice to have a panel which will include this also, if it is needed, or an inquisitiveness on the part of the pathologist to say, AMML, please add this and get it done. If you are suspecting M6 variety of AML, which is the worst to have, these two are the worst to have, then you can run a glycophorin A, which is very diagnostic for AML M6 on the surface of the cells. If you are suspecting AML M7, then we can do CD41 and CD61, which is very specific for AML M7. Both these two have a poor prognostic value. Now, the leukemia panels that are run, we would have liked these to be included as part of the routine, because if upfront we know that it's a glycophorin A or a CD41, 61, we know what to tell our patient's relatives or the patient as to whether to spend money or not, or should we go for transplant at an earlier stage. It's worth having this immunophenotypic data, but unfortunately everyone doesn't give it. Please remember, in AMLs, 78% of the times, 1333 is positive. HLA-DR negativity has its value, and I'll show you the next slide. HLA-DR negative is very helpful in diagnosing APML. If you have a pre-B ALL, which is also CD34 positive, I didn't show you CD34 because we've been too busy. If they're also CD34 positive, as occurs in 70% childhood, very good prognosis. We'll tell the parents spend. And I'll tell you one sad story. It was a young girl, and I don't want to mention the community, but it was a young girl. At the end of the day, when they came to know that she's got a leukemia, they chose not to treat, saying that anyway, if I treat her, she's not going to be able to bear a child. No one's going to marry her. So what is the point in treating her? This is a discussion which we have with some of our patients, the relatives. They tell us this. What's the point in treating this girl? She's not going to be able to bear a child. So we would like not to take treatment. Where it was a good prognostic one.